This might be the last video in this course. This is Nick, nurse anesthetist from the Fresh RN team, here with perhaps the last video in the critical doing course. I'm not sure yet, and I haven't bothered editing any of these videos so I look more awesome and articulate than I actually am. If it is the last one, I should summarize everything that you've learned and talk about how much this experience has means so much to me and how much you mean to me. But it's probably getting a little long by now, so I'll just go ahead and talk about the subject I want to discuss, which is clinical tips. So most of this I'm just going to write down some ideas about putting in IVs, although I can say pretending that this finger is an IV, because I probably have IVs here at home like every nurse does accidentally without emptying their pockets, but let's not rat me out here. And usually we use a certain angle to put in IVs. Remember that you can adjust that depending on the type of vein you're looking at, where you're going in the skin. Sometimes you have to adjust your angle, just as for those of you who place arterial lines, you realize that that's a much steeper angle than once you get a flash, you lower it, and it's a bit of a different process, which I won't go into since most of you aren't CRNA students. So with IVs, sometimes you can even take a sterile glove and bend it slightly upward so the needle is more pointed like this, depending on the entry. And that's more of like for advanced users, because most of us, when you try that, just end up with a crooked IV needle and a sheepish look on our face. So what I'm really going to talk about is pharmacology. Because I'm a nurse anesthetist, it's one of my favorite subjects, and we really haven't talked about it much in this course for fear of me going off on tangents and you never learning anything else other than pharmacology. And most of this is thinking, not necessarily just watching medicines do their thing. So the first thing I want to talk about is beta blockers. I think I mentioned already that in cases of shock, in cases of hypovolemia, you'll have a high heart rate, and you don't necessarily want to treat that with beta blockers because that high heart rate is like the last gasp, the body trying to overcome the fact that there isn't that much blood, or that in the case of shock, all the blood vessels have dilated due to toxins. And again, the issue is primarily a very simple one, that like any pump, it needs stuff to pump, and there isn't enough blood to pump, so it pumps more often so it can pump blood more effectively through the system. So you don't want to stop that by giving especially a long-acting beta blocker. Esmolol is often your friend in these cases. I typically don't use it in anesthesia because all it does is buy you 2 minutes of time, and you're like, I used a rather expensive medicine and my patient looked good for 2 minutes, and then now they're right back to where they were before. But especially if you're unsure of what the issue is, it can give you those few minutes to decide things. Obviously in critical care nursing, things are measured in the time unit of minutes. For anesthesia, it's seconds. In med-surg floors, it might be hours as far as wanting results and how quickly you want them. So, esmolol, even at higher doses, that itself can bring a patient into a code situation. So it doesn't mean it's completely harmless, but of course it doesn't last as long as low pressure. Low pressure is probably my favorite IV beta blocker because it's predictable, you can titrate it, and again, you can always give more of these meds. So if you have a PRN order 1 to 5 milligrams of low pressure, sure, fill up your syringe with 5 milligrams of low pressure, because we've talked a lot about time management, but that doesn't mean you have to give all 5 and walk away. You can give one, go do something else. Actually, let's be more specific. You can give one, assess your patient, then look at what's going on and decide whether you need to give the other 4, 2 milligrams, whatever is going on. And every situation is different. Labetalol is almost in the same category of hydralazine, where you're going to have effects for hours, and especially in the case of hydralazine, those effects might not start for 20 minutes. So that's more of a long haul where there's clear indication that yes, this patient is always hypertensive, or they've been hypertensive for a long time, and this will help. I had one case where I just gave the normal PRN 400 milligrams of PO labetalol to this patient, went off to lunch, came back, and I was like, pressure 70/30. Apparently she doesn't need the labetalol anymore, but no one's really updated the record. So that was completely my fault and my lack of nursing judgment that led to that situation. So, and the hydralazine story brings up the story of what if the drug you're using works temporarily and then you're in the same situation. Because remember, this is critical thinking. The very root of nursing, because I'm about to say the word root, the very root of nursing is find the root of the problem, solve that, and then we don't have to just chase symptoms for our whole shift. Yes, we look busy. Yes, the doctors are proud of us when we treat all these things and give all these medicines and do all these interventions, but we're just kind of passing our time. I realize the American medical system is all about treating the symptoms so you get the same patients over and over as a constant revenue source. But that's not really the subject of these courses. So one time I had a patient, extubated him. He was calm for a little bit, then he started getting a little wild, gave him propofol. I repeated that about 5 or 6 times, and I was like, you know what? Honestly, he's just a jerk. I can't change his personality with a med. He's just gonna swing at people and fling his legs everywhere, and that's just who he's gonna be every single time he wakes up, because of the 50 milligrams of propofol will work 5 minutes, then he's a jerk again. So I use another drug. It still didn't change his personality, but in this case, Precedex calmed him down. So, and again, if it's a patient's personality, you're gonna have a lot more issues. Like, yes, patients are anxious, but do you really need to give them Xanax every 3 hours, or perhaps a conversation, bringing in family members? And granted, sometimes family members are the reason that someone's so anxious, so that's not always a great idea. But try to get to the root, find out why do they need this pharmacological therapy over and over again. And that way it can help you decide what is the best response. I know that as registered nurses, you're not deciding on the medicines in many cases, but you can still steer the physicians in. For instance, this patient needs sedated, morphine and Versed will work fine because we're going to be here for days. Or this patient, propofol is an excellent choice, or perhaps Precedex because we're not really sure when we want to wean him, but we want to do so quickly, and he has some pain needs, but not enough for us to put him on a fentanyl drip. So there's a lot of thoughts that go into all this. Another drug, one of my favorites, in part because I'm starting a ketamine clinic, is ketamine, where it doesn't affect your respiratory system like other drugs, so it's good for your chronic pain users who you still want to breathe on their own because you don't want to intubate them and things of that nature. So the more you learn about drugs, especially when you're in the ICU and you have a sheet of PRN drugs, the more likely you are to make the wise decision. And these are absolutely individual decisions. I spoke earlier about personality traits, how mine always tries to do individual care to a fault, as opposed to people who are constantly in a routine. But often when you're looking at different choices for medications, it really helps look at the patient individually, and that's the best clinical tip I have for you, is to just look at each situation individually. And thankfully, difficult clinical situations are ones where your nurses, your coworkers like being brought into them. I had a patient once in the ICU, and on night shift we would all sit around and think of ideas on how to fix him. It was great fun. He died, unfortunately. None of our ideas were really good. He was really sick, and it taught all of us in the unit a lot about how to manage patients, especially very tricky patients who you give a little bit of the wrong drug and then they'd be very sick for shifts on end. So all of us became better clinicians through that experience, sharing our knowledge.